Head trauma. Welcome to this lecture on head trauma. In the USA, about 500,000 people have head injury per year, and 10% of those die before reaching hospital. And a majority of head injuries are mild, 80%, and moderate and severe head injuries account for 10% each. Approximately 50% of trauma deaths in the USA are associated with head injury, usually involve the scalp, skull, and underlying brain tissue. Head injury has a high disability rate, and the best management is the ABC approach of ATLS. Local statistics in the East African Medical Journal published in 1999, Muyembe and Suleiman did a study that showed about 40% of patients who had head injury was due to a traffic accident, and 78% of those patients died. That is significantly more than US statistics, and 64% of those deaths occurred outside hospital. The objectives of this lecture therefore are to review anatomy and physiology relevant to head injury, learn principles of management of head injury patients, evaluate head injuries using a mini neurologic examination, which is a rapid way of assessment, identify management techniques for specific head injuries. In the skill stations, we'll also demonstrate the ability to assess various head and maxillofacial and neck injuries which are usually associated, discuss clinical signs and outline priorities for initial management of such injuries. Physiology. The brain resides inside a hard skull, and if there's an increase in intracranial pressure, there's usually egress of brain tissue. The emergency physician cannot do anything about primary brain injury, and the main role is to prevent secondary brain injury by optimizing cerebral blood flow. Important physiology to note is determinants of intracranial pressure, and one important one is mean arterial pressure and cerebral perfusion pressure. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure, and it's very important in maintenance of adequate perfusion and nutrition. And in the emergency management, we want to keep cerebral perfusion pressure high. The Kelly-Monroe doctrine states that intracranial volume, composed of the brain, blood, and cerebrospinal fluid, is a constant, and if any of those parameters increase, it does so to the detriment of the other parameters, so that when you get a hematoma, it leads to decreased cerebral perfusion and also decreased cerebrospinal fluid. This is a diagram of how the normal brain is inside the skull. It's a coronal view showing the intracranial spaces, the ventricular spaces, the cisterns, and brain tissue. When there's a hematoma, it results in midline shift because of pressure on one side, and that can lead to ankle herniation, which leads to oculomotor palsy, and that is an early and usually quite significant sign in head injury. An ipsilateral fixed dilated pupil. If tonsillar herniation occurs, invariably leads to death because of compression of the respiratory center. This diagram shows the vicious cycle of increased intracranial pressure, where hypotension leads to decreased cerebral perfusion pressure because of decreased cerebral blood flow, and that results in vasodilatation to increase cerebral blood flow, but that increases intracranial pressure, and we go back to square one. And these are parameters that can increase hypotension. Causes of vasodilatation: increased PaCO2, decreased PO2, and certain drugs. In head injury also you can get obstruction to CSF from hematoma or from cerebral edema, and that leads to decreased cerebral perfusion pressure. These graphs show the relationship between systemic blood pressure, intracranial pressure, and cerebral blood flow. And for most part, changes occurring in blood pressure and intracranial pressure tend to keep cerebral perfusion pressure at a constant, but at a certain point there is critical increase in intracranial pressure that leads to a drastic fall in cerebral blood flow and hence cerebral perfusion pressure. Mechanisms of head injury are blunt trauma from motor vehicle accidents, falls or assault, or penetrating trauma from stab or gunshot wounds. How do we conduct a mini neurologic exam? Firstly, we assess the patient's airway, breathing and circulation and resuscitate accordingly. And the mini neurologic exam is a quick way of assessing disability, that is the neurologic status. It comprises of two parameters. One is the AVPU scale and two is pupillary response to light. In AVPU scale, A stands for alert, V stands for a patient who is not alert but responds to voice, P stands for a patient who responds only to pain, and U is for a patient who is unresponsive. The mini neurologic exam is a rapid way of assessing disability, but we still must conduct a Glasgow Coma scale, which is usually more detailed and takes more time, and a GCS is required. Glasgow Coma scale is required for grading the severity of head injury. The Glasgow Coma scale is an important scale used to assess the severity of head injury. It has three parameters: eye-opening, verbal response, and best motor response, the details of which are listed in this slide. The Glasgow Coma scale was developed for trauma and is now used also in other incidences of altered consciousness. And the lowest possible score is 3 and the highest possible is 15. In a study done in Glasgow comparing initial GCS mortality, there was a significant correlation between percentage mortality and initial GCS, where the lower the GCS, the higher the mortality, as shown in this table. Severity of injury uses the Glasgow Coma scale to define mild, moderate, or severe injury. And the GCS for mild injury is 14 and 15. Moderate head injury is 9 to 13, and severe head injury is when the GCS Glasgow Coma scale is between 3 and 8. And severe head injury is also defined as coma, where patient does not have a verbal response, does not open eyes, and does not obey commands. In severe head injury, the main priority is to secure the airway to maintain cerebral oxygenation. Initial management of head injury follows the ATLS principles of airway management, breathing, circulation. Then we check for disability and finally exposure. And in cases of coma, we also do a finger stick to check, usually for low blood sugar, which can be a cause of coma, or certain drugs as well. And the Glasgow Coma score is very important. This flow diagram shows the management for minor head injury, where after taking history and physical exam, we determine the Glasgow Coma scale. If it's between 14 and 15, with the normal history, normal physical, then we admit the patient for observation and we can investigate as required. But if abnormal, we admit the patient for observation and we investigate accordingly. In moderate head injury, where the GCS is 9 to 13, we secure the airway, do primary survey, then take a history physical examination and do labs. And all patients in this category should be admitted and treated accordingly. If they deteriorate, then we need to deal probably surgically with the problem. In severe head injury, we do primary survey where we check the airway, breathing and circulation. We secure the airway, we give supplemental oxygen, we assist breathing, make sure the patient is breathing adequately, and we check circulation, the blood pressure. Remember, mean arterial pressure is very important, and we also want to avoid an increase in blood pressure. Then do secondary survey to find associated injuries. We do Glasgow Coma score and evaluation, pupillary reaction, because it's very important to determine if there's an injury to the oculomotor nerve. And then in management, we give mannitol and anticonvulsants. The role of mannitol is to reduce intracranial pressure, and anticonvulsants reduce the possibility of convulsions, which usually increases oxygen demands of the brain and might aggravate any injuries that are there. If the patient is stable enough, we do a CT scan, usually very important, and we can do an angiogram as well, and usually we consult the neurosurgeon early. Early consultation is very important. We now turn our attention to management of focal head injury, penetrating trauma or blood trauma. And focal head injury means an injury to a specific part of the brain. It can be subarachnoid hemorrhage, which is usually quite common from trauma. The cerebrospinal fluid is usually bloody, and it can occur or usually associated contusions. Subdural hematoma, also quite very common. 30% of severe head injuries have subdural hematoma, and occurs from rupture of bridging veins in the subdural space. And this is worse in elderly patients with a shrunken brain who might even suffer a chronic subdural hematoma. And the CT scan shows a Mund's liver. In this diagram, you see evidence of a subdural hematoma. And epidural hematoma occurs in 1% of all head injuries, but it's quite well known because it's most dramatic in presentation. Occurs as a result of a dural artery tear, usually the middle meningeal artery at the pterion, which is a weak part of the skull. It's quite dramatic in that patients can be quite conscious one moment and then deteriorate rapidly and die, usually called a lucid interval. Skull fractures should raise our attention to possibility of an extradural hematoma, and sometimes even without a skull injury, scalp lacerations can result in significant blood loss, especially in children, because the blood volume is proportionately lower. This CT scan shows intracerebral hemorrhage with resultant effacement of the ventricles on the affected side and midline shift. This shows bleeding in the frontal lobe and will result in some neurological deficit as well. As opposed to focal brain injury, the commonest causes of head injury are so-called diffuse brain injury, and here there is sometimes not possible to see a distinct injury. And one example is when you have a concussion, it's usually a transient loss of consciousness, and neurological function is usually restored after some time. And sometimes these patients may have long-term neurological malfunction depending on severity. And a worse condition, and which is quite common in severe head injuries, is when you have diffuse axonal injury, which results in shearing and tearing forces on nerve fibers, and you might get coma with no focal lesion. There's usually also autonomic dysfunction, and it is usually hard to distinguish from hypoxic injury as a result of not attending to a comatose patient early enough. General interventions, IV fluids are important, but in moderation, because we don't want to increase cerebral edema. In fact, in some cases we give mannitol, which helps to reduce intracranial pressure. Give Lasix, also reduces intracranial pressure as a second-line therapy. Steroids are not indicated in head injury, but anticonvulsants are, and they reduce potential for convulsions and prevent an increase in cerebral oxygen demand. We hyperventilate the patients, actually controlled ventilation to keep PCO2 between 25 and 30, because sometimes hyperventilation results in vasoconstriction, which is more injurious to the brain. Surgical interventions, this is definition management, treatment of wounds, management of depressed skull fractures, management of intracranial lesions, and that is why we need to consult neurosurgeons early. In summary, therefore, remember, airway, breathing, circulation always first. Remember, we resuscitate the patients according to need, evaluate the severity of head injury, evaluate other injuries as well, and we assess neurological status frequently so that we manage the patients as required, and we intervene depending on the level of injury, and early neurosurgical consult is important. Thank you for your attention.